and that is our next lectures on endohepatology, EUS guided liver biopsy, and portal pressure gradient measurement. It is my pleasure to introduce Dr. Marvin Ryou. He's the Director of Endoscopic Innovations at Brigham and Women's Hospital in Boston. And thank you for being here, Marvin. Go ahead.
It's a pleasure to be with you all at the 4th annual course in Advanced Procedures in Interventional Endoscopy. I'd like to thank the course organizers at the University of Colorado, Dr. Mihir Wah and Dr. Menard Katcher, for the very kind invitation to speak today. My name is Marvin Ryou, and I'm at Brigham and Women's Hospital. I'll be speaking on EUS guided liver biopsy and portal pressure gradient measurements. These are my relevant disclosures. Ken Chang originally coined the phrase endohepatology, which is the growing intersection between hepatology and endoscopy. Historically, when you thought of endoscopic offerings for patients with liver disease, we were usually talking about luminal endoscopy, such as endoscopic variceal banding or ERCP for post-transplant biliary strictures. Over the past 10 years, however, there has been an expansion of specifically EUS-based offerings for patients with liver disease. And I think this is what has caused people to reconsider what is endoscopically possible for this patient population. At the moment, I would say these are the diagnostic and therapeutic offerings of endohepatology. For diagnostic, we have EUS-guided liver biopsy and EUS-guided portal pressure gradient measurements, which are in clinical use and will be the focus of this talk. We are also in the early stages of EUS shear wave elastography, which can potentially be more accurate than FibroScan, particularly for patients with NAFLD or NASH. Now, for therapeutic, we have EUS-guided gastric variceal coiling, as well as esophageal stenting for refractory esophageal variceal bleeding. And I would say that there is growing evidence for both of these in the treatment algorithm where they are available. Additionally, we have EUS-guided direct gallbladder and biliary access and drainage procedures, which has seen increased popularity with the advent of Axios. And finally, in preclinical studies, we have EUS-guided TIPS creation and EUS-guided chemotherapy injection of liver tumors. So we will focus on these two topics for the rest of this lecture. We'll start with EUS-guided liver biopsy. Obviously, EUS provides extraluminal views that extend our endoscopic reach. And one example of this is EUS-guided liver biopsy. For those of you who have not seen an EUS liver biopsy before, this is what it looks like. First, just wanted to point out the liver is one of the easiest structures to identify. And second, the view is nearly 100% reproducible because the liver is at most 1 to 2 centimeters away from the gastrointestinal wall, regardless of body habitus. So you'll notice the needle entering the screen just right of the transducer, followed by the initial puncture. Doppler interrogation allows for avoidance of intervening structures such as blood vessels or bile ducts. The needle is then retracted and another needle excursion is performed. This is usually performed under suction, the details of which we'll get into later in this lecture. Sampling of both the right lobe and the left lobe is certainly possible. The left liver, as shown here, is sampled in transgastric fashion, while the right liver is usually sampled with a transduodenal approach. The procedure is relatively quick, and the time in the recovery bay is on the order of 30 to 60 minutes in most centers, not the multiple hours we used to do with percutaneous needles. We always perform in antecedent upper endoscopy. So EUS liver biopsy may make particular sense for patients who require an endoscopy anyways, say for variceal screening or H. pylori biopsies, or if EUS is needed for other reasons. For example, for ruling out choledochal lithiasis, for abnormal liver function tests, or if you are planning to do a portal pressure gradient measurement. So again, the theoretical advantages of EUS-guided liver biopsy include the ability to do bilobar sampling, the ability to provide other clinically important endoscopic or sonographic information, and we believe decreased pain from the avoidance of abdominal wall puncture, as well as a faster post-procedural recovery. The disadvantages include the need for deep sedation, as well as probable higher cost. This is a meta-analysis from Mohan et al. On EUS liver biopsy, which is probably already somewhat dated because it included studies that used EUS biopsy needles like the QuickCore that are no longer commercially available. In any case, the pooled diagnostic rate was 93.9%, and the pooled adverse event rate was 2.3%. Because of the inclusion of outdated biopsy devices, I suspect that the actual diagnostic rate and adverse event rates are better than these figures, but this is what I will quote when asked about efficacy and safety. Now, which needle should we use for liver biopsy? Literature would suggest that FMB core needles are ideal. Our group did a comparative study in human cadaveric livers showing a 19-gauge FMB needle was superior. Two retrospective series, one from Mayo Jacksonville and one from Singapore, have both shown FMB needles to be superior as well. Finally, a randomized control trial from Geisinger showed also that 19-gauge FMB was superior to 19-gauge FNA. Now, which FMB needle is best? Well, 3 studies so far, one from UC Irvine, one from Florida, and one from Lehigh, have all shown the 19-gauge Francine tip to be better than the 19-gauge fork tip needle. What about wet suction versus dry suction? Wet suction is filling the needle lumen and sometimes a small amount of the syringe with either saline or heparinized saline, such that the liquid serves as a buffer of sorts upon activating suction, and that there is less specimen fragmentation as well as blood clots. Both Nieto's group in Florida and the Geisinger group have demonstrated that wet suction yields superior results. And finally, how many passes and how many actuations? Well, here again, our colleagues from Geisinger have shown that bilobar biopsy, in other words, both right and left, is better, particularly in NAFLD due to regional variations. Additionally, they have shown that more actuations are better. Specifically, one pass with 3 actuations will produce better yield compared to one pass with 1 actuation. So to summarize what we think we know from the current literature regarding optimal technique for EUS-guided liver biopsy, 19-gauge core biopsy needle, specifically the Francine tip, 2 passes, or bilobar, multiple actuations with each pass, and finally the wet suction technique with either saline or heparin. How does EUS compare with interventional radiology? There is some controversy regarding the answer. Geisinger and University of Florida both did single-center retrospective studies concluding that EUS was comparable to percutaneous. The Orlando group published a randomized controlled trial this year in which they randomized 40 patients to EUS 19-gauge Francine tip needle, 2 passes, versus single pass 16 gauge percutaneous biopsy. And they found the percutaneous was superior to EUS. The optimal specimens were 58% versus 23% respectively. All cases were diagnostic, but the total specimen length was 26 millimeters for percutaneous versus 16.5 for EUS. 16.5 millimeters for EUS, and that was significant. There was no statistical difference in complete portal triads, however. Additionally, there were no adverse events in either group. Of note, the mean costs for EUS was $3,240 US versus $1,824 for the percutaneous arm. There was an accompanying letter to the editor that pointed out that no suction was used in the EUS arm, and that this was not standard protocol, and that the percentage of optimal specimens was much lower than what had been published in the literature thus far. Okay, so we're going to pivot now and talk about EUS-guided portal pressure gradient measurements. Just by way of background, portal hypertension is a complication of liver cirrhosis. Historically, the hepatic venous pressure gradient, or HVPG, has been measured to reflect the degree of portal hypertension and is the single best prognostic factor in liver disease. It predicts risks of variceal bleeding, ascites, hepatic encephalopathy, hepatocellular carcinoma, and both 1-year and 5-year mortality. However, HVPG relies on indirect measurements of the portal pressure by way of the wedged hepatic vein pressure, and therefore misses pre-sinusoidal causes of portal hypertension. HVPG is frequently performed through a transjugular approach at the level of the hepatic vein. Both the free and the wedged hepatic vein pressures are recorded. The wedge pressure theoretically transmits across the sinusoids and serves as a proxy for portal pressure. The difference between the wedged and the free pressure is the hepatic venous pressure gradient. 0 to 5 millimeters of mercury is considered normal, while 6 to 10 millimeters of mercury is considered portal hypertension. And anything greater than 10 millimeters of mercury represents clinically significant portal hypertension. In contrast, EUS-guided portal pressure gradient directly measures both the hepatic vein and the portal vein. The difference here is called the portal pressure gradient, or PPG, or the portal systemic gradient. The PPG measurement system, seen on the right, is comprised of 3 individual components seen on the left. They include a compact manometer, non-collapsible tubing, and a 25-gauge FNA needle. A heparin flush is connected to the PPG measurement system, and pressures are serially recorded. So I'm going to show you a clinical case of a man with liver function test abnormalities, new mild ascites, and mild splenomegaly. His liver biopsy did not show evidence of cirrhosis, but the possibility of nodular regenerative hyperplasia. His HVPG was normal, but there was a suspicion that this was erroneous. And so hepatology consulted us for EUS portal pressure gradient measurements. This is the initial endoscopy that showed absence of varices, but did show the presence of portal hypertensive gastropathy. And then we switch over to the EUS portion. Sharp liver tip, smooth contours, and we're doing something called endoscopic palpation, where we're sort of indenting the transducer into the liver parenchyma, and the indentation here is quite good and reflects a non-cirrhotic liver. We then perform hepatic and portal vein pulse wave assessments, and this is the characteristic quadriphasic waveform of the hepatic vein. You contrast this with the monophasic waveform of the portal vein. The PPG device I've already shown you, and what we're going to do here is sequential hepatic vein followed by portal vein access with a 25 pH needle. So we start with the hepatic vein, and usually it's the middle or left hepatic vein, and we're accessing, in this case, the middle hepatic vein in a transgastric, hepatic fashion. And we go across the liver parenchyma because we want the needle path to be tamponaded by the liver parenchyma. This is probably safer than accessing the main portal vein. And once we're in the hepatic vein, we'll inject the heparin flush. We'll see the numbers go up, and then it'll plateau, and you saw that it plateaued around 10. We'll then measure these in triplicate, at least, and then after we are finished with obtaining our measurements, we'll withdraw the needle under Doppler assessment over 30 to 60 seconds. And then we'll repeat the same steps with the portal vein. And so this is the umbilical portion of the left portal vein. It looks different here, as you can see, than the hepatic vein with the thick hyperechoic vascular walls. And we'll serially inject the heparin. We'll see the same numbers go up and then plateau. We'll measure these in triplicate, and you saw there the portal vein numbers were 17. So then the gradient will be the difference between the mean pressures of the portal and hepatic vein. And in this particular case, this was 7.0. So there was portal hypertension. This was most likely nodular regenerative hyperplasia with pre-sinusoidal portal hypertension that was missed on HVPG, but was accurately assessed using EUS-guided portal pressure gradient measurements because PPG is able to detect pre-sinusoidal, sinusoidal, and post-sinusoidal causes of portal hypertension because of the direct measurement that it entails. The first animal study for the PPG measurement system was performed by Ken Chang's group. In this porcine study, simultaneous EUS PPG measurements and HVPG measurements were performed. Moreover, they were performed in the same hepatic vein. And as you can see in this graph, comparing transjugular versus EUS measurements, there was a near one-to-one correlation across all pressure ranges. In their subsequent first human study, Ken Chang's group published their experience with their first 28 patients. They reported 100% technical success without any adverse events. Of note, the PPG range tested was a wide range, 1.5 to 19 millimeters of mercury, and they found excellent correlation with clinical parameters of portal hypertension, including varices, portal hypertensive gastropathy, and thrombocytopenia. Last year, a multi-center collaboration including UC Irvine, Dallas Methodist, Mayo Jacksonville, and our group at Brigham and Women's submitted an abstract detailing our experience with our first 49 patients. Similarly, technical success was 100% without any procedure-related adverse events. The PPG range was again very wide, 0 to 24.3 with a mean of 6.78 millimeters of mercury. And again, there was excellent correlation with clinical features of portal hypertension. We are witnessing incorporation of EUS portal pressure gradient measurements in diagnostic algorithms to answer important clinical questions. This was a recent communication from the Piedmont group in Atlanta detailing the application of EUS PPG in 11 patients with end-stage renal disease suspected of having concomitant advanced liver disease. And the clinical question they were trying to answer is whether these patients needed just kidney transplant or combined kidney liver transplant. 10 of these 11 patients had successful reproducible EUS PPG procedures. One patient had cirrhosis confirmed with another 2 patients suspected of cirrhosis, And based on the EUS PPG results, 9 patients, or 82%, were cleared for just kidney transplant alone, while 1 patient, or 9%, was referred for a combined liver-kidney transplant. So to summarize, EUS liver biopsy is safe, allows for bilobar assessment, probably causes less pain than percutaneous, and has shorter recovery period. The yield of EUS liver biopsy compared to interventional radiology, however, remains unclear. EUS PPG is safe and potentially more accurate than HVPG, as it directly accesses the hepatic and portal veins. And finally, combining EUS liver biopsy with EUS PPG can create an endoscopic one-stop shop for the diagnosis of patients with suspected or chronic liver disease. I'm going to conclude with this final slide regarding who may benefit from combined EUS liver biopsy and PPG measurements. The referring physician is usually asking one or some of the following fundamental clinical questions about liver health, such as, does the patient have liver disease? If so, what is the etiology? What is the fibrosis level? What is the level of portal hypertension? And if there is portal hypertension, are they responding to intervention? And so I have found in my experience that these referrals tend to fall into certain buckets. So bucket number 1 is preoperative risk. These patients may have certain lone features suggestive of cirrhosis, like low platelets or splenomegaly. In both a biopsy and PPG measurement can help clarify the situation preoperatively. Bucket number 2, uncertain etiology or uncertain fibrosis level. If there is uncertain etiology, then the liver biopsy is obviously more important. But for uncertain fibrosis, say with a discordant FibroScan, both the biopsy and the PPG may be helpful. Bucket number 3, known portal hypertension. Is the intervention like non-selective beta blockade working? This category is interesting because it invokes the need for serial PPG measurements. And bucket number 4, clarifying an uncertain HVPG. Like the clinical case I shared, EUS PPG can occasionally clarify a confusing HVPG, either corroborate or provide a more accurate assessment. And finally, a plug for the ASGE Endohepatology Special Interest Group. If you are interested in joining, please contact Steph Morales at ASGE at the email shown here. Thank you again for your kind attention, and to the course organizers for the invitation to speak.
Thank you, Marvin. That was great. While we are waiting for any questions from the audience for Dr. Yu, I just had a quick question. So Marvin, what did you have to do to convince your hepatologists and transplant surgeons, or whoever you had to do the convincing at your institution, for them to kind of accept that EUS guided endohepatology is something they should do versus the traditional IR guided route that most places are doing? So what steps did you have to take to get this up and running?
Yeah, Mihir, that's a great question. And thanks again for having me on, by the way. So I've at my hospital, I've been beating the drum for EUS liver biopsy and EUS portal pressure gradient measurements for a very long time. And so our hepatologists, like any group, they will run the continuum in terms of early adopters and more conservative. And so, I would say that at this point, even now, after several years of producing good data for EUS liver biopsy and portal pressure gradient measurements, I still have naysayers among referring hepatologists, but I do have a group of hepatologists who are really believing in it. And I think it's key to really, number one, get the word out that this is an emerging area, and that there are theoretical advantages over conventional biopsy and HVPG measurements that are being done by interventional radiology. I think sharing cases like the one that I showed in the presentation, where we're able to diagnose pre-sinusoidal portal hypertension through EUS PPG that HVPG, happened to miss. I think cases like that can be very illuminating. And so when these types of cases are discussed at multidisciplinary conference, that can be an opportunity. So I think right now we're sort of in a dissemination stage in terms of getting the word out, and I just see the momentum building. Another kind of I'd say like another response to your original question would be, I have often made the argument to our clinical leadership that when we are sending patients to interventional radiology for transjugular liver biopsy and transjugular HVPG measurement, doesn't it make more sense to keep those patients within our division and perform an endoscopic ultrasound-guided liver biopsy and portal pressure gradient measurement? And I think that type of argument also makes sense to clinical leadership as well.
Thanks, Marvin. I think Steve has joined in. I don't know if Steve, you have any?
No, I've been here the whole time. I've just very nice talk, Marvin. We've had the same hurdles here in terms of convincing the hepatologists that this is a change from their usual practice that would be beneficial. I guess the other thing that would be refreshing is to hear your experience in terms of complications. It sounds like the complication rate so far has been extremely low in busy centers. Is that still your experience? And are you concerned about any particular characteristics of this patient population that you would be hesitant to proceed with?
Yeah, great question, Steve. So for EUS liver biopsy, our adverse event rate has been low. Our parameters are INR less than 1.6 and platelets greater than 50,000. And so I would say that with those parameters in mind, we have not had any major complications, and I hope that continues. In terms of the EUS portal pressure gradient measurement, this is a 25 gauge needle. And so if you do it the way that I kind of showed, and this is the methodology that Ken Chang and the industry folks are espousing, I think it makes a lot of sense in terms of safety. It's a transhepatic access, and the liver parenchyma will help to tamponade the access site. And so if you do it that way, I think it's very, very safe. We still use the same cutoffs in terms of INR and platelets, but I think that you could probably liberalize that even more with the portal pressure gradient measurements. I always invoke a small risk of bleeding, infection, maybe thrombus formation, but I've yet to see it.
Great, thank you.
Thanks. I think in the interest of time, we're going to move on. We're running late. So Marvin, thank you again for joining us. And if there's any more questions that come through the Q&A, we'll send them your way, or they can reach out to you later in the course of the day as well. So thanks. Let's move on to our next topic, which is interventional EUS, tips and tricks for gallbladder drainage, gastrojejunostomy, and EDGE. And our speaker is Dr. Shyam Varadarajulu. He's the medical director of the Digestive Health Institute at Orlando Health in Orlando, Florida. Unfortunately, Dr. Varadarajulu is actually out of the country right now at another meeting, so he couldn't join us, but we have his lecture that we'll play for all of us.
Hello, this is Shyam Varadarajulu from Orlando, Florida. It's a great pleasure to make this presentation, and I want to thank Dr. Wag for his invitation for me to speak on tips and tricks for gallbladder drainage, gastrojejunostomy, and EDGE procedures. So I'm going to begin with gallbladder drainage, and there are three common indications currently for this indication. One, EUS guided drainage is performed in lieu of cholecystectomy for high-risk surgical patients with acute cholecystitis. Secondly, it is used for conversion to internal drainage in patients with pre-existing percutaneous cholecystostomy tube. And finally, it can also be performed for malignant biliary decompression when ERCP and EUS have failed, although this is quite an uncommon indication. Why is EUS guided approach popular? Simply speaking, the main alternative to EUS guided drainage is percutaneous drainage, and current data proves that both techniques perform equally well from a clinical standpoint. However, EUS guided drainage likely has fewer adverse events and less need for re-interventions compared to percutaneous approach. There are two common methods by which gallbladder drainage can be undertaken. One is called the hybrid freehand approach, where a lumen-opposing metal stent is deployed over a guide wire. And the two main advantage of this technique is that when lamb's placement is being performed, you can prevent accidental damage to the contralateral wall of the gallbladder, particularly in patients when the gallbladder is not very well distended. And also, it minimizes the risk for stent misdeployment. The freehand technique is a more common approach where it is fairly straightforward and a lumen-opposing metal stent is placed directly into the gallbladder, and I think a majority of practitioners adopt this approach. These two videos illustrate the hybrid freehand technique and the freehand method for gallbladder drainage. In the hybrid technique, in this particular patient who presented with obstructive jaundice, a mass was seen at the region of the cystic duct, occluding the neck of the gallbladder. It was fairly hypoechoic and straightforward. So using a biopsy needle, the mass was sampled, and on rapid on-site evaluation, this was confirmed to be adenocarcinoma. Then using a 19 gauge needle, the gallbladder was punctured, and a 0.025 inch guide wire was coiled within the lumen of the gallbladder. Being a non-contouring enhanced system, the tract was initially dilated using a ERCP cannula, followed by a 4 millimeter balloon. After retracting the balloon, a non-contouring enhanced lumen-opposing metal stent was then deployed with deployment of the distal flange and then the proximal flange within the duodenal bulb. In the second video, this is the standard technique that is being currently used with the cautery enhanced system. It was a 78-year-old patient who presented with right upper quadrant pain and fever, and the patient was not a good surgical candidate and elected to undergo drainage via endoscopic techniques. So as you can see, the CT scan showed minimal changes of emphysema around the gallbladder. So using a 15 millimeter lumen-opposing metal stent, the distal flange is first released after application of electrocautery, and then following that, a proximal flange is deployed within the GI lumen. And this procedure was performed without any aid of guide wire. In this particular case, we also placed a double pigtail plastic stent as the patient had several stones, and we were concerned of the patient developing acute cholecystitis due to stent dysfunction at a later time.
I think the video has paused and we're looking into it. Please bear with us and sorry for the inconvenience.
The video is still playing according to my timeline. I'm not sure what's happening within the video itself.
Gallbladder drainage is that one has So one of the caveats of gallbladder drainage is that one has to be careful because when the echondoscope is advanced deep into the stomach, it can push against the gallbladder and a stent can be deployed. And after the echondoscope is withdrawn, the stent can actually recoil and there can be internal migration into the GI lumen, resulting in frank perforation. And in this particular case is a nice illustration where you can see that the echondoscope is deeply bent and then the gallbladder is very further away from the GI wall and a stent is being placed. So in this particular circumstance, one has to be very, very careful about deploying a luminopposing metal stent from the stomach. In fact, it might be preferable to deploy it from the duodenal bulb to minimize the risk for internal migration and possibly a perforation. There are certain precautions that can be undertaken. During the procedure, it's very important to minimize contrast injection because excessive injection of contrast can result in sepsis. Secondly, some patients may not have any symptom relief at 24 hours because the lumen of the stent can be occluded by stones and debris. And in these cases, it can be overcome by placement of a plastic stent. Alternatively, if the patient does not improve very well, one should suspect gangrenous or a perforated gallbladder as a reason for lack of symptom relief. There are a couple of controversies. Nobody knows how long these stents should be left indwelling. We know that if luminopposing metal stents are left long term, adverse events can happen. In one particular study, it was estimated to be 7% at a follow-up of around 9 months. And the most common adverse events were acute cholecystitis due to stent blockage and stent migration. Other adverse events include upper GI bleeding and ulceration, which have been reported between 4 to 6 months. Therefore, there are two management options that have been proposed. If a patient has got a very short survival time, then the stent can be allowed to indwell permanently. Whereas if the patient is healthy and survival is expected to be prolonged, then the stones within the gallbladder can be removed by cholecystoscopy using a standard gastroscope, and this has a success rate of more than 90%. Following that, either the lamps can be removed or the lamps can be exchanged for double pigtail plastic stent. Again, this is not a evidence-based recommendation. This is just consensus by experts. In summary, compared to other methods, EUS has the lowest chance of recurrent acute cholecystitis and highest rate for clinical success. While percutaneous methods are effective, they do have high rates of unplanned admissions and reinterventions. And transpapillary drainage via ERCP, although uncommonly practiced, is associated with high rates of adverse events. I will now move to my next lecture topic, which will be gastrojejunostomy. So EUS-guided gastrojejunostomy is commonly performed for malignant indications for the diseases of the GI tract, although occasionally it's also being performed for benign indications. And why is EUS-guided gastrojejunostomy popular? It's popular because the outcomes are comparable to an enteral stenting, and some experts have suggested that the rate of adverse events may be lower. And additionally, the rate of symptom recurrence appears to be significantly less for EUS-guided gastrojejunostomy than conventional enteral stenting because there is frequent tumor overgrowth into the stent or there is and stent-related dysfunction, whereas with EUS-GJ, this limitation can be overcome. There are multiple ways how a EUS-guided gastrojejunostomy can be performed. Although 6 techniques have been described, the 2 most common techniques are, one is called the direct method, where a luminopposing metal stent is deployed directly into the fluid-filled jejunum from the stomach. It's a technically simple procedure. Unfortunately, there can be complications because of stent misdeployment or an or overlapping bubble loop, and this can result in perforation that will require urgent surgical intervention. The second technique is called the EPAS method that was described by Dr. Itoi, where a lumen-opposing metal stent is placed in a fluid-filled medium between two anchoring balloons. This is a safe technique. However, it's not popular because the technology is not available uniformly worldwide, although it's safer. So these are two videos that is going to show these techniques. The first is the direct technique, where in this particular patient, one can see a very, very distended stomach, secondary to a luminal cancer. And the patient does have a very adjacent jejunal loop. So methylene blue mixed with contrast and saline is now injected across the luminal obstruction to distend the small bowel. And then once the echondoscope is positioned in the stomach, the small bowel is directly punctured using a cautery enhanced system, first with a 19 gauge needle, and once contrast is aspirated and confirmed, a lumen-opposing metal stent is then subsequently deployed by application of cautery. The distal flange is first released, followed by the proximal flange within the GI lumen. In the second technique, which is called the EPAS method, that has been described by Dr. Itoi, the echondoscope, the endoscope is first passed, and then a guide wire is advanced across the obstruction into the jejunum. Subsequently, contrast is injected to opacify the small bowel. Once that is done, in this method, the dedicated balloon is advanced over the guide wire into the small bowel. And it's got a double beaded pattern, and this is to illustrate the positions of the two balloons that are now passed over the guide wire. And the balloons are mixed with contrast mixed solution, and they are first inflated to anchor the small bowel. And you can see the balloons, and there is also a good intervening space, and this intervening space is now filled with fluid. The small bubble loop in between the balloon is then punctured using an echondoscope directly using the lumen-opposing metal stent, with first passage of the distal flange and then the proximal flange is released into the GI lumen. Following this, the balloon is then removed. So this technique is called the EPAS method, and the advantage of the technique is that it anchors the small bowel and minimizes the possibility of misdeployment.
Please continue with the video.
The video is currently playing.
Can you move it ahead 5 seconds?
Lumen-opposing metal. There are some caveats with EUS-guided gastrojejunostomy. This procedure can be performed only when the lumen-opposing metal stent deployment area is less than 20 millimeter from the jejunum. And in 25% of the procedures, it may not be possible to deploy the stent. And some Japanese investigators have identified means by which failed procedures can be identified. And this is by performing a contrast study and the anatomy of the ligament of Treitz gives an indication of the success of the procedure. And they postulate that in patients who have a type 1 anatomy, where the distance is very minimal, like less than 6 millimeters, it's much easier to perform. Whereas in patients where the distance is much higher, like 15 or 20 millimeters, the procedure is likely to be unsuccessful. And these are categorized as patients with type 2 or type 3 anatomy. And this constitutes approximately a third of the patients. So there appears to be a mechanism by which success can be gauged depending on the relationship of the region of the ligament of Treitz on the stomach to the jejunum. Other caveats: one must be familiar with intra-channel deployment of the proximal flange. Generally, some investigators would like to look at the black mark for release of the proximal flange. With this technique, one has to get accustomed to releasing the flange inside the channel so that the procedure can be successfully completed. There also used to be a notion that ascites was a major contraindication, and it looks like the presence of minimal to moderate ascites does not appear to preclude successful completion of the procedure. So in summary, EUSGJ is an effective alternative to enteral stenting and possibly surgical bypass. One development that might accelerate the use of the technology will be the development of dedicated T-tags or other techniques which will improve the safety profile of this procedure. And my last section is going to be US-directed transgastric ERCP, or the EDGE procedure, where in patients with Roux-en-Y anatomy, a stent can be placed either gastrogastrostomy or through a jejunal small limb in the remnants at the region of the remnant stomach and into the excluded stomach. So why is EDGE procedure popular? This is outcomes in 178 procedures, and one can see that the procedure is successful in close to 95 to 98% of the patients, and a successful ERCP can be performed in close to 50% of patients during the same procedure. A limitation appears to be the presence of a residual fistula that can be managed at a later time. But however, compared to double balloon assisted ERCP or a laparoscopic procedure, the success rates are quite high. It can be performed in an endoscopy suite with excellent clinical outcomes, and therefore this procedure is becoming increasingly popular. There are 3 steps involved in performance of the EDGE procedure. The most common is the freehand method, where a lance is deployed, followed by anchoring of the lance, particularly if the patient is scheduled for a same session ERCP. In this particular video, we are going to demonstrate the technique. Here you can see a patient with a stomach that is now insufflated by irrigation of water into the excluded stomach from the residual pouch. Following installation of water, a lumino-posing metal stent is successfully deployed with the distal flange in the excluded stomach and the proximal flange via the remnant stomach. This patient is now going to undergo a same session ERCP. The lumen of the lambs is then dilated using a balloon, and following dilation, the excluded stomach can be very well visualized. So the stent is now secured by placement of a guide wire, and then using overstitch device, the lumino-posing metal stent is anchored to the remnant stomach.